Hello, everybody, and welcome to week 7 of the Dementia Information Series. Thank you so much for coming this evening and joining us. And before I introduce our guest speaker for this evening, June Rimar, I'd like to mention next week is our last week. And for 7 weeks now, we've been talking about the person you're looking after, ways to look after them, things to think about. And next week is self-care for the caregiver. So next week, our session is about you, and it's going to be led by Vanitha Nair, our caregiver educator, who you met in the home safety presentation. So I do hope you'll be able to join us next week, and we're going to have some caregivers speaking also. So please do come next week. So tonight, I'm really pleased to introduce June Rimar, who has been with the Mississauga Halton Local Health Integration Network since 1998. And she has been working in the placement services since 2007. She's been doing community presentations since then. And she really enjoys engaging with her audience. And of course, like all of us, we are struggling to be comfortable with this virtual online platform. June will welcome questions from the audience. And I just want to mention that June is very, very passionate about her work in placement services. And she's even shared a story that she went back to Denmark, and while she was home on vacation, or while she was in Denmark on vacation, she went into her long-term care facilities there. She does care very deeply about her clients in long-term care. And so June, I'm going to turn the presentation over to you. We will take a break at 8 o'clock, and June will take questions as we go, I may have mentioned, and we will be reading them to her as we go. So thank you, June, and over to you.
All right. Hi, everybody. I'm going to just share my screen. Is that what I have to do now, Sandy?
Yes.
Okay. That seemed easier than when we did it the first time. Hold on. Okay, hang on a second. There we go. Does everybody see that?
Yep.
Is that good?
Phew. There you go. Yep, you're in.
All right, great. Okay, well, I'm really delighted to be here this evening, and I do want to acknowledge the very challenging time that it is for everybody, for caregivers with their loved ones in their home, for our long-term care homes as they struggle to take care of the residents that they have, and our hospital partners who are really bursting at the seams at this time. So just wanted to, mention the challenges that we know that we have. And I'm just here today to just sort of go through the process. I am more than happy to answer any questions, as Sandy mentioned. But just, if you have anything that you want to talk about on a personal level after, you can certainly get my extension. I'm more than happy to answer any questions, or, have anybody reach out to me, anytime after the presentation is over. So just in general, what I'm here to talk about, I understand that Sandy, I think, and Vanitha talked about home and community care, some of the services that we provide. So I won't go into great detail on that. Basically looking at housing options, and then certainly the long-term care process. So the Mississauga Halton Lynn is comprised of 7 geographic areas, but I'm sure everybody has heard in the news that there's big changes coming with healthcare in general. And this initiative started prior to the pandemic. So things are sort of, I don't want to say on hold, but they're moving more slowly in terms of things being changed over to Ontario Health. There will be 5 Ontario Health teams, and the Mississauga Halton Lynn is part of the Central Health team, and that would include Central West, North Simcoe, Muskoka, Central, and then us. So some of the services that we provide, I'm sure were mentioned to you: nursing, personal support, physiotherapy, occupational therapy, speech, social work, and dietitians. Right now, we know that we've had challenges getting providers. Certainly, families have expressed that at this time they don't want to have somebody come into the home. So we do find that you know, while we do have these services available, sometimes we do have challenges getting them into the home, but we are certainly doing our best to provide the care that people are really looking for. Other services that are available, this is prior to the pandemic, there was friendly visiting, but I think they're doing the Zoom and sort of phone calls, those kinds of things, rather than the face-to-face, obviously. Meal delivery is still going on. Transportation services is still going on. Adult day programs, unfortunately, they are closed at this time, but I know that they're doing virtual programming. And short stay respite is another item that we are no longer providing in long-term care homes, because all of those short stay beds have been turned over to long-term care beds in an effort to get crisis people placed and our hospital patients out of hospital. So we are not doing long-term care short stay, but you can get short stay still in retirement home settings. And then, of course, supportive housing buildings and retirement homes in general as part of housing, and then long-term care. Some of the services that were provided prior to the pandemic were convalescent care, short stay rehab programs. Now, they have been closed down since March. And we actually used to have a program at Post Inn, but that program closed in 2018, and those beds were changed to long stay beds. But we had a restore program at Cooksville Care. When the pandemic hit in March, all those restore beds were closed because, of course, the very nature of that is people going in and out and, you know, doing active participation in programming. And with the pandemic, it was felt that that would be one program that we should no longer admit to during the pandemic. We also have special behavior units. We are admitting to the behavior unit when the home is not on an outbreak. We've had some admissions to the Sheridan Villa Behavior Unit and Cooksville Care Behavior Unit. These programs are helpful for those folks in the community who really cannot have their needs met in long-term care homes because they perhaps have some behavioral problems that need to be addressed in order for them to be stable and go into a long-term care home. We also have Behavior Supports Ontario through the Alzheimer's Society. Those programs are really being done virtually, but we are still accessing them and having our psychogeriatric resource consultants consult virtually with our service providers. And we're also having our community service workers in our adult day programs virtually. They're doing some behavioral support. And then we're also utilizing the Behavior Supports Ontario staff to help with transitioning into long-term care. We have rapid response nurses that go in to do medication reconciliation. We have a strong palliative care program for those people experiencing end of life in their home. We have increased services and we have experts in palliative care. We have nurse practitioners, and those nurse practitioners are very busy these days because they work as liaisons between the hospital and our long-term care homes. So their purpose really is to avert people going from long-term care into hospitals. So those nurse practitioners will go in and sort of consult and see whether or not the care can be provided with support in the long-term care home rather than sending folks to hospital. And then we have mental health and addiction nurses. And during this very difficult time, we're finding there's a real need for mental health and addiction support services. So that's a well-utilized program now. So part of the programming that we have to get folks out of hospital is the My Way Home program. And this program's intent is to get people out of the hospital setting when they no longer require acute care and into a different setting, whether it be in their own home, whether it be in a retirement home. And we would provide an elevated level of service in the home in order to support somebody being there to await long-term care placement. So really, people, once they're stable in hospital, we really want to make sure that we do everything we can to get folks out of hospital and into a setting, and then perhaps going to long-term care, or perhaps, if things go well, remaining at home if possible. So some of the options that are available for housing would be seniors housing. And so seniors housing is accessed through in Oakville and Burlington through Hatch, which is the Halton access to community housing, or in Peel through Peel Living. We know that they have really long wait lists. I actually phoned last week out of curiosity just to find out what the wait lists are looking like. And, you know, the lady I spoke to said, we're not really giving out wait time estimates because, you know, like we say in long-term care, somebody either has to pass away or move out in order to create a vacancy. They're in a similar situation where somebody does have to move out or perhaps pass away to create a vacancy, and that's very difficult to predict. But what we do know is the trends are that the wait lists are long. They do also have a crisis list that's separate. So if somebody happens to be either palliative or homeless, they can be expedited in terms of getting up the list to get into a housing, such as Oscar, the Ontario Oakville Senior Community residence there on Lakeshore. Seniors apartment are somewhat different, and those are just buildings that cater to seniors, and sometimes they're subsidized. There is also condos, and now I've got to remember, I think it's called NORC, naturally occurring retirement communities. Those are condos that tend to have an older population, and sometimes within those buildings, they have some, you know, activities and meals and those kinds of things that seniors can enjoy and get a little bit of sort of socialization and you know, camaraderie. But again, within those buildings, those programs are sort of on hold with COVID. So hopefully, you know, with the coming good news of a vaccine, and hopefully people being able to move more freely and to socialize, we'll be able to see some improvement with programming. Now, retirement homes are an excellent option for people. They are, you know, many times beautiful buildings. They have lovely sort of units. Sometimes there's suites that you can share, but most times they're sort of single units. But the challenge with the retirement home is that you are basically paying for the room and usually board, meaning like a meal, or sometimes 2 or sometimes 3 per day. But if anybody requires any additional care, those costs are layered on. So if you need medications, sometimes, or if you need help with personal care, housekeeping, all those costs are layered onto the cost that you are paying in a retirement home. And so you can vary anywhere. I think I've heard the cheapest lately is around $2,500 per month, but anywhere up until 11 or 12,000 per month if you require additional services and if you're on a memory care floor. And lately what I've been hearing is that some of our retirement homes are asking folks to private hire because their loved ones may be wandering and are not easily sort of kept in their rooms during this difficult time. And so I've heard people paying $20,000, if you can believe it, in those retirement homes. So great option for people. I certainly know that the level of care has increased over the years, but just be mindful of the fact that the costs can increase. So when you go in and you get a quote and you're looking into that, you know, you make sure you ask lots of questions. And one excellent resource would be this senioropolis.com. They have a book that they put out called A Comprehensive Guide to Retirement Living in the Greater, I think it's actually in the whole province of Ontario now, but you can access that through that website, senioropolis.com. And also the ORCA, which is the Ontario Retirement Communities Association. That's a sort of voluntary group that retirement homes join, and they sort of, you know, they have a reporting line and that kind of thing. But what's new, not new anymore now that I'm looking at 2020, but in 2010, they started to set up a body called the retirement, let me just think now, I'm going to forget what the acronym for, but basically it was the it's an overriding body, and they did write some legislation around the retirement home registry. And so they have a list of rules, and it's based on the Long-Term Care Act, but it's not the same in terms of the accountability. But they do at least have a reporting line. So if people have any concerns, they can report it to that. And I've included the website there. And just before I came on today, I was watching the news, and they were talking about this organization being not called out, but just basically saying that more needs to be done to protect people in retirement homes just as much as in long-term care homes. And so I just happened to see that before I came on this call. So then if people are not appropriate for a seniors building, and they're not appropriate for a retirement home, or they don't have the funds to maintain themselves in a retirement home with the level of care they need, because they all sort of limit what they can provide. Usually it's around a maximum of 90 minutes on a memory care floor. And if you need more than that, then you have to private pay, and that's when we see the costs go up. So if people are really in a situation where that is not sufficient to be able to manage somebody's care needs, then we start to look at long-term care. And long-term care homes, we have 27 homes in the Mississauga, Halton area. And those homes provide a level of service which would generally exceed what a retirement home can provide. They have nursing and personal care. They have, on-call physicians who don't see patients regularly. Like the staff will say to the physician, you know what, you need to see so-and-so, in this room, or something, if any family member has any concern, you can certainly reach out. But at least you are assigned in each unit to a specific physician, and there is always a physician on call, so that there's always somebody that they can check in with if there's any sort of medical emergency. They provide treatment and medication administration. They provide help with dressing and bathing. Usually in long-term care homes, people get a couple of baths per week, depending on whether or not they're incontinent. And then some of the other bathing would be sponge bathing. They provide 24-hour supervision. And this is an important point, because sometimes people think that my loved one is living on their own and they are not safe, so I need to get them in the place where somebody can watch them all the time. So they're having falls in their apartment, that kind of thing. But really, it's the availability of 24-hour supervision that we're talking about. It doesn't mean that somebody's going to be able to sit with your loved one, for 24 hours a day. So it's important that people know it's the availability, it's having somebody there. But, if your loved one is falling in their own apartment, then chances are they could have a fall in long-term care as well. It just means that there's somebody there to monitor, to remind your loved one to use their walker. If they happen to be in a wheelchair and are getting up, then they have a chair alarm. If they are climbing out of bed at night, they have bed alarms, and then they would lower the bed and put 2 mattresses on either side, just to make sure that somebody doesn't fall out and hurt themselves. So that's what they mean by 24-hour supervision. So basically what the patient is paying is room and board, and that includes laundry and special diets. The Ministry of Health actually pays for the care portion. So the patient pays for the room and board. I just learned after doing this for a number of years that they actually are funded for some $8 and something in change to provide meals. So one thing I have, people ask me, what kind of complaints do you have? And one thing I will say is sometimes people say the food isn't necessarily delicious, but you know what, they do provide dietary services, and they do accommodate special diets, and they do provide like a well-rounded meal, and each resident is able to choose between 2 different options. So that is good. And then the other thing which is important is pastoral services. There's usually a chaplain, whether they're, just with that home, where it might be somebody coming in and then also social and recreational programs. Now, we know that when people are living alone and they are not engaged socially, that they really do decline. And we have seen this with COVID, so much so that people are not participating, they are isolated in their own homes, or even when they're with family members, they're not necessarily maybe engaged in the programming because people are busy lives. Many times seniors are living with their kids who are either working at home or they are, having, other responsibilities. So in long-term care, the programming that happens is invaluable. Now, when COVID started, a lot of the programming was put on hold. We saw more programming opening up. So they would do small group activities. They would do one-to-one activities in patient rooms and that kind of thing. So everybody knows it's important. So they've tried to work around it during COVID, but they really have minimized contact, in the sense that if they are going to do a program, they have to be physically distanced and that kind of thing. So it's just a little bit different the way they're doing things. But when the home is actually on an outbreak, then that's limited to just people being in their rooms and then somebody coming in and doing a one-to-one activity. So a lot of people will ask the question, and feel free, if anybody has any questions, you can certainly reach out and stop me, because I know I'm going through this more quickly. Some of the people will often ask the question, how do I know it's time to start the process for long-term care? And probably about, oh my gosh, almost 10 years ago, the Ontario Health Minister decided that we really needed to do something different with behavior supports, because we were noticing an increased number of behaviors going into long-term care. So they got this program together and they started to really look at how we're going to support transitions into long-term care. And so I had gone down to this place in Toronto, a hotel, and they were having a big presentation, and there was a caregiver who came to the meeting and they were telling her husband's story. And so up on the screen, they were really documenting the journey. And this poor lady had a very, very difficult time. And, all the LHINs from around, at the time, CCACs from around the area were there. And it turned out that that particular lady happened to have been somebody who was a patient of the Mississauga Halton LHIN. And so, to my manager's credit, she walked over and talked to her and told her, I'm really sorry for what's happened in your experience, but I'd like to make things better. So this lady has been a consultant with us for many years, and helped share some of the things that she found needed improvement. And one of the things she said is that she really felt she should have been, her husband should have been on the wait list before. She really felt that part was missed. And some of the things that she said for her were triggers, and certainly we've built on that as well, is incontinence. Once her husband became incontinent, that was really a trigger that she could not continue to do this ongoing. She was not a large lady. She was a petite little lady, and her husband was strong, and he was having some resistance to taking his medication, that kind of thing. And so for her, that was really, kind of when she said, I can't continue to do this. And I don't know if any of you have been listening to the CBC and CTV lately, but I know Lisa Raid has been very vocal in her journey in terms of working, helping her husband cope. And she I just actually saw her on the news this morning and talking about that resistance and how difficult that can be, and then lack of sleep, that being a real trigger. For everybody, the patient as well as the caregiver. Now, right now, when we look at respite options, we did have quite a lot of respite options, and I know Acclaim has this wonderful program waiting to open, and having people to be able to go and stay overnight, even for 1 or 2 nights. We had NORAs, we had long-term care homes offering short stay respite. These were great programs so that people could get a break, because sometimes just having 1 or 2 weeks where you can just relax, or go on a vacation or that kind of thing really helps you rejuvenate and then go back to your caregiving duties. And unfortunately, during COVID, we find that these things are not available. So the one place they are available is in a retirement home setting, but of course there's a fairly high cost associated with that. People just telling us that we can't do this anymore, making sure that our care coordinators are saying, listen, we're listening to you, we hear you, you tell me when I can't do it, when you can't do it anymore, you tell me, and then we start to look at alternate planning. Hygiene issues, we know that sometimes people who have dementias are reluctant to be showered. We find this to be a problem. And knowing that, you know, that increases your risk of a urinary tract infection, and it's just basically difficult for family members. I had a man ways back who was refusing to be washed, and I said to his son, like, he hadn't left his house, and I said to his son, do you think that you can, like, maybe get him to go to Tim Hortons, like, just to get him out of the house? And he said to me, he hasn't bathed in so long, like, I just don't feel that I can do that. So we got some Behavior Supports Ontario staff in there and started working with him, and through baby steps, got him to accept care and got him cleaned up, and eventually got him into a long-term care home setting. Nutrition and hydration issues. Hydration in particular is a challenge, but also making sure that folks are eating. But when people become dehydrated, we know that we can see some delirium set in, increased urinary tract infections. And when people are not eating properly, they become weakened, increased risk for falls. Those are some of the triggers for sure that are challenging. Changes in what they can do for themselves. So I had somebody years back when he was on the crisis, his wife was on the crisis list, and she was, I gave a bed offer on the Friday, and he was humming and hawing, and he felt like he just wasn't ready, and he actually declined the bed offer on the Friday. And when I came in on Monday morning, I think I had like 13 messages from him, because in that short period of time, his wife, who he could help get to the washroom or at least transfer her, was all of a sudden unable to get up. She was, you know, a little bit combative at that point, and he said, oh my gosh, is that bed still available? I want that bed. I can't do this anymore. And I mean, in this particular case, we realized that probably some medical acuity was going on, so she ended up going into hospital. But that shift can sometimes happen gradually, where somebody is able to help their loved one, and then all of a sudden, you know, that person is no longer a one-person assist, is all of a sudden a two-person assist, or it's too heavy for the person to help. So those are challenges that our families are having. Changes in medical stability, like an unstable diabetes. When sometimes people with dementia and diabetes, all of a sudden you can't stop them from eating. They're going and having sweets and that kind of thing. So their diabetes gets all out of whack. That can create a whole host of problems. Getting people to take medications, that can be very problematic. That's where we get our rapid response nurses involved. If we want to make sure that people are on the right meds, taking the right meds, they can act as the go-between between the doctor and the family and the rapid response nurse. And, you know, this is a big one for us, is changes in family support, because, you know, when the pandemic started, so many people were working from home. And so they were providing support for their loved ones. And then they phone us and say, now what I got to do, I have to go back into the office. And so that person who was able to supervise and keep their loved ones safe is actually no longer available, because their office has asked them to come back to work. So this has created some pressures, changes in financial support, and then of course, caregiver illness and even caregiver death. We do know that caregiving puts most strain on people. And so, you know, a lot of times when we realize that long-term care should have been started, when we see the caregiver is starting to have health issues of their own. So these are triggers. When somebody comes into the home and they're doing assessment, these are the things that they're going to look for. And they're going to say, you know, maybe we need to start to talk about long-term care. Now, I unfortunately, we discovered before this presentation that our communications department unfortunately didn't update this, but I wanted to just mention to you, I will email you the correct link to this particular slide, because during COVID, unfortunately, there are no tours. That stopped immediately. I think back at the end of February, middle of February even, a lot of our long-term care homes said, listen, we know there's something out there, there's a virus, we don't know a lot about it, but we don't want to run tours through our homes. And since that time, families have had to make decisions, and they're difficult ones, for their loved ones to go into long-term care homes without actually going into the buildings until the day that they take their loved one there. And that is very difficult for people. We do have online videos. Not all the LHINs have this. I know Central West doesn't, Burlington doesn't either. So it's very difficult to make these decisions sight unseen. I do want to tell you that when these videos, when you do look at them, for example, Tyndall, you'll see up there on the screen, in Erin Mills Lodge, the Ministry of Health with Directive 3 has said that there will be no more admissions into any 3, 4, 5, or 6 bed basics. Some of the homes, like those 2 in particular, they had 4 people sharing, and what they discovered with this pandemic was that that was a recipe for disaster. So once that directive came in, and I want to say that it was in May, our long-term care homes who had 3 and 4 bed basics, they started to, any vacancy they got, they started to change their configuration of the room so that only 2 people were in their basic room. So when you're looking at those videos, just be aware that there are no longer any rooms in long-term care homes that anybody from the community would be admitted to that have more than 2 people in them. And as a consequence, some of those rooms are actually quite large because they used to have 4 people in them. Because anybody, even if you're sent to hospital from that long-term care home and you're returning to the hospital, you actually will not go back into the same room. You will go to a room with only 1 other person in it. So that is a tremendous improvement. That, of course, has an impact on the wait list because we lost a lot of beds. But just in terms of infection control, it's an important step for sure. Now, in order to fill out the paperwork for long-term care, there's certain eligibility requirements. And one of them is that you have to be 18 years of age or older. The other one is you have to have a valid and current OHIP number. You have to have exhausted the publicly funded community-based services. So if your care needs can adequately be met in the community, then you might be a low priority, or you may not in fact meet the eligibility requirements at that time until your care needs increase. There should be an element of perhaps risk to self or others. You need frequent monitoring or assistance. You need access to a nurse, and that your care needs can actually be met in a long-term care home. So, for example, somebody who perhaps, let's say, has a diagnosis of ALS, right now we're having some challenges. I've had a number of ALS patients who have what they call a BiPAP and a cough assist. So it's a breathing apparatus that actually pushes air into the lungs, and the cough assist helps get some of the phlegm out of the lung. Right now, that has become a barrier, and it really has been a barrier actually all along, but in particular during the pandemic because of the need to clean the machine and that kind of thing. So that person's care needs actually cannot be met in a long-term care home setting. Another thing would be somebody who, let's say, requires a ventilator, somebody who has a wound that is so significant that they require dressing changes, which, let's say, twice a day dressing changes on top of turning and care, like physical care, dressing, bathing, those kinds of things, and feeding. If somebody's care needs exceed probably about 3 to 3.5 hours of care per day, then their needs would be considered too great for long-term care. And then that's when folks would have to look at a complex continuing care situation. Now, I'm sure everybody has been listening to the news. And so they are going to be looking at increasing the number of hours per resident, but that's not going to be happening in the near future. But they're looking, I think it was 2023, if I'm not mistaken. So they're looking at moving towards increasing the number of hours of care that each resident gets. But if somebody exceeds the current level of care that's funded, then they would be, they wouldn't be eligible. They would probably be complex continuing care. So in order to start the process for long-term care, you have to request a placement assessment, and that you would do by calling either the ACT team. So that's the number with us is 905-855-9090, and you just press 0. We have folks, we're all working from home right now. So, but we have phones in people's homes, so you can access somebody in the intake department, and they will start the process. It'll be a phone interview, and then eventually it'll be a setup for a care coordinator to assess. The H&HB, it's a similar process as well. If your loved one is already receiving in-home service, then it would be a call to the care coordinator to say, listen, I want to talk to you about long-term care, and that would involve a home visit and you know, an assessment in home. If your loved one is in a hospital setting, then that person would be assessed within the hospital if they were only going to be placed from the hospital and they couldn't return to their home. So those are the sort of 3 ways of accessing service. One of the challenges that I have heard from folks when I've done presentations in the past, when they've actually been able to speak to me freely, is that when they've called in and they've asked to have their loved one assessed, our people who answer the phone will say, well, does your loved one know that you're calling? Is your loved one in agreement to the assessment? And this can sometimes create challenges for people who have dementia and perhaps aren't able to make the decision. So, you know, rest assured, if you run into that problem, then you need to push and really, if you need to escalate it to a manager, because we don't want folks turned away, because that phone call we know is very difficult. And we have to be very mindful when we, you know, assess somebody for long-term care, that person is in agreement to go if they are able to make decisions for themselves. We don't want to take away anybody's right to make decisions, but we also know that when people have dementia, they are going to resist. And if they are not able or don't understand what their care needs are, that creates challenges for their loved ones. So please, if you run into a barrier like that, if you can ask to speak to somebody else, you can ask to speak to a manager, you can call somebody in the placement department. I've had people call me before, because we don't want people to get discouraged and turn away. It's a fine balance, to be truthful, between respecting somebody's right to make decisions for themselves, but also making sure that we're there to help our families who we know are hanging on by their fingertips. So a lot of times people will say to our care coordinators, okay, you can come for the visit, but I don't want you to mention anything about long-term care because my mother is going to be so angry and she's not going to want you to assess her. The problem with that is that we do have to tell the patient the purpose of our visit. So if you know that your mother or husband or anybody that you're calling for is going to be challenging, and is going to be upset by the call, please tell the care coordinator when you're setting up the home visit and say, listen, I'm really worried. This is what I anticipate happening, so that the care coordinator is aware and they will choose their words more carefully. You know, I'm here today to plan for your future. Your daughter's doing a great job, but we want to do a backup plan just to say, like, what happens if your daughter is no longer able to do this? We want to make sure that you're safe. Sometimes folks get upset when they're at the home visit, and then the care coordinators say, you know what, let's just talk about something else and we'll come back another time. Sometimes it takes a couple of visits before we can get people in agreement, or, you know, just properly assess that person's ability to make decisions for themselves. So the application process, it's not a quick visit, I can tell you that. Usually the visit takes, I would say, a couple of hours, because There's a lot of paperwork to be done, and you want to properly see that your loved one is properly assessed. So plan for at least a couple of hours on that initial visit. So what comes out of that visit is a RI assessment is done. We get a health report from the doctor's office. We do a behavioral assessment. We get consult notes. We get any additional information about your loved one. And we really thoroughly assess the person in terms of what they can do for themselves, what you're helping them with. Are they incontinent? Are there any behavioral issues that we need to look at stabilizing before we get somebody admitted to long-term care? And the other important piece that happens is that we assess somebody's capacity. So I'm going to talk a little bit about that after. But I just wanted to let you know that you can select up to 5 choices. I've had people say to me, I was told that you have to have 5 choices, and that's actually not true. You have up to 5 choices for a regular non-crisis application. But if you only want 1 or 2 choices, that's entirely up to you. But what we tell people is, because we're dealing with such extensive wait lists at this time, it may be in your best interest to have more choices. But if you live in, a place that you want to, just have that one choice, just be aware that at every home visit, you should really be discussing and looking at the wait times and seeing how you're doing. And you may want to add choices in the future. When you have your initial first visit, though, try to have one choice ready, because if you come and all the paperwork gets done, you get determined to be eligible on that day, and you have your choice sheet ready, then you get placed on the wait list on that day, and that's to your advantage. But you have up until 6 weeks to add any additional choices. So as long as you have one choice for the initial visit, then you have up into 6 weeks to add any additional choices and get that original position date. And any choices you add in the future after that 6-week window, then you're going to have that new choice as the date that the new facility choice sheet is received by the LHIN, just so you know. So capacity, this is a very important responsibility, and it's designated to our LHIN care coordinators. They're the only ones who determine capacity, and it is capacity to make long-term care decisions. It is not healthcare decisions, it's strictly long-term care. And it is only the LHIN that can do that. Sometimes people will think their doctor can do it, but no, only the LHIN can assess somebody's ability to make decisions around long-term care. And the first part of that is their ability to understand the information and what's relevant to making the decision for long-term care, and their ability to foresee the consequences of that decision. So does somebody understand what their care needs are? Do they understand what their challenges are? If we go into somebody's home, like I'll give you an example today. I just got a call about a crisis. This lovely, sweet gentleman was telling us that he is absolutely fine. He doesn't need any help. And in the meantime, he is wanting to bring his wife home from long-term care. He can absolutely take care of her. They live in a multi-level house. She is absolutely wheelchair bound. There's no possible way. And yet he does not understand that is the situation. He thinks he's completely fine to drive, even though he's confused. And that's the type of thing too, that we would question somebody's capacity. It is, do they understand what their limitations are? Do they understand they need help? And do they understand that they are living at risk? Because there are those folks who choose to live at risk. They understand they have health conditions that mean they are living in a precarious situation, but they are aware of it and they appreciate their situation, but they still choose to live at risk. Somebody can be capable, choose to live at risk, and family members, as frustrated as they are, can't make that decision for them. So capacity is a very tricky thing. The important thing for you to know is that it is our responsibility to assess somebody's capacity when they are at their best. So if somebody is sundowning at 4:30, we're not going to do a home visit at that time. We're going to try and come in at 10 o'clock in the morning when that person is able to make decisions. And that sometimes can be frustrating for families, but it's our responsibility to assess somebody when they're at their best. If somebody has a urinary tract infection and is experiencing delirium, we can't assess their capacity. If they're medically unstable in hospital and they're not in a state where we can do that, we have to wait. If a person is incapable of making decisions, we inform them of the finding of incapacity, and we let them know that they have a right to contest that finding of incapacity through the Consent and Capacity Board, and then we have to assist them to do that if they choose to do so. If they are incapable and they accept the decision of incapacity, then we're going to say, listen, you know what, it seems that, you know, you may be having a bit of trouble now. We're going to ask your power of attorney here. We need the document and see whose power of attorney to make that decision for you. And usually, you know, people are agreeable because that was why they, you know, put together a power of attorney. Or if there is no power of attorney, then we have to go to the Substitute Decision Maker Act. The important role of a power of attorney is to act in somebody's, on their expressed wishes. So if you're writing a power of attorney, it is in your best interest to tell the person what it is you wish, what you want for your future, what kind of decisions, healthcare related, long-term care related, that you want to make. If that person can act on their expressed wishes, then they need to do that. But there are times when somebody might say, under no circumstances am I to go into a long-term care home. And I've seen that written in a power of attorney. But if it is not safe for that person, and the power of attorney for personal care feels that that person is at risk, and the professionals feel that way as well, then it is their responsibility to act in that person's best interest. So first express wishes, and then in their best interest. Those are the important roles. And you have to be available. So, you know, we have to be able to reach you. I had a situation it was a couple of years ago, and I was trying to reach this power of attorney to make a decision. And you know, the man, he was actually a physician in BC. And so here I was trying to reach him all the time. And, you know, I didn't have I had his work number. We couldn't get a bed offer acceptance. When I finally reached him, we said, you know, listen, you know, we really need you to be available to make decisions. That's part of the role and responsibility. And he said, you know what, to be honest with you, this person, I've been her power of attorney, but I haven't seen her in 20 years. She used to work for me 35 years ago. So in this particular case, he did make the decision, but then he rescinded his responsibilities, and this particular file went to the public guardian because this person had no other family members. So making sure that you're available and willing to make the decision is part of the responsibility. We always have to have a copy, because so many times we get the copy and we see the way it's written, and it's actually written jointly. And that means that both people, or all three people, whoever is named, have to sign and participate. If it's written joint and severally, then one person can sign, but we still need to know that everybody's in agreement. And if people are not in agreement and they can't come to an agreement after discussion, then the decision for the bed offer actually goes to the public guardian and trustee. So it's really helpful if folks do try to work through those sort of differences. And that's where the people who work in the Behavior Supports Ontario team or the Acclaim support people who can help you to better understand the disease and the trajectory and that kind of thing, and sort of get everybody on the same page, because sometimes that's really what the barrier is. The person who's providing the care says, listen, I can't do this anymore, but the sister who lives out in BC is saying, how can you do this? You know, getting everybody on the same page to truly understand where people are at. Now, if we don't have a power of attorney, then we have to go to the substitute decision maker. And this is where we have this hierarchy that I've just shown you here. If for example, we are looking at 3 kids, and it would be all 3 kids equally, but we can get a letter completed to say that, sister 2 and sister 3 are okay if the brother makes the decision. We put that in writing, then we can just go with the one person, but we have to have it in writing just to make sure that it's legal and we're making sure everybody's in agreement with who's making the decision. Now, I'm going to just go through waitlist management. And you know what? This first category was always a very quick one, but I do want to take a few moments here to explain something to you, because this category has been expanded during COVID. So the readmission category is the very, very top of the wait list. So let's say your loved one is in a long-term care home and they have actually been admitted to hospital for a medical acuity or for a psychiatric leave. If their medical leave exceeds 30 days, they actually lose the bed in the long-term care home in which they were living. And if it exceeds 60 days in a psychiatric leave, then they lose their bed. But when they are stable medically or behaviorally to go back to the home, they're placed at the very top of the list as a readmission category to go back to the home. And generally speaking, we get folks back pretty quickly. I don't want to say every time, because if it's a basic secure male bed, something like that, sometimes we have to wait. But in general, I've had really good success in getting people back to the home. But what we found now during COVID, and the ministry has changed the rules around leaves. So if somebody has their loved one in a long-term care home right now, and they feel concerned because of an outbreak or because of just not being able to see their loved ones, some people have opted to take their loved ones out of a long-term care home and take them to live in their own home. And this can be a bit challenging, and I'll tell you a little bit about that after. But once the outbreak is over, then they can be placed on the readmission category to go back to the home. And that part is good. So there's no more vacation leaves. There is only, if you take your loved one out of the home, you are discharged from the home. And then once the outbreak or even the pandemic is over, depending on people, how they feel, then they can go back to the long-term care under that very, very high priority to readmit. One of the challenges when people opt to do that, and we go through like a question, like we usually do a teleconference with the family, the home, and then our care coordinator and myself, if it happens to be one of my homes, because we really don't want people taking their loved one out to a risky situation. So we want to make sure folks know that, listen, you're no longer covered by the physician at the facility, so you will have to find a physician in the community who will take on your loved one's care. That can be a challenge, but it's an important part for medications and those kinds of things. We want to make sure families' homes are set up so it's safe. We want to make sure that we have the services that we can put in to support them. We want to make sure that the physical, do you have a room for them? Do you have a bathroom that they can be bathed in? We want to make sure that if there's any wound, skin breakdown, that we've got the proper folks to go in and that we can really safely manage somebody in their home. So there's a real discussion that takes place before somebody does that. But we have had a number of people, to be honest with you, take their loved ones out. And we have had some folks go back once the outbreak was cleared in the summer. And I have been receiving sort of an increasing number of calls from people who are asking those questions about taking their loved one out during an outbreak. Right now, we have a lot of homes in outbreak in the Mississauga, Halton area. HNHB, Burlington area is not nearly as bad as our area, but certainly Central West and Brampton and that area has a lot of homes in outbreak. So people are certainly asking those questions. Now, crisis. I want to tell you, we have seen a tremendous increase in crisis. When the pandemic started, the directive from the ministry is that hospital patients be put on crisis as well, because we knew that there was going to be a backlog with regard to people in hospital. So we had to get them discharged from hospital in order to create some capacity to have those COVID patients, some of them from long-term care homes, who needed to be treated in the hospital. We also were mindful of all the surgeries that were being canceled and folks who were having diagnosis of cancer and having to wait for treatment. So the pressures on the system are tremendous. And so that is why we have seen an increase. People in the community, people in the hospital, our crisis lists have grown. The next priority in the, I wonder, sorry, I want to go back up, pardon me, sorry. I just wanted to check if I had a slide on this spousal thing, but I don't. So one of the categories, and I can tell you, I have had a couple of people, spouses go in to the long-term care homes. So we do have a priority for people. So if your loved one is in a long-term care home and you have care needs of your own, so it's not just that you want to go there and be with your loved one, you have to have some care needs. If you do, then you get a higher priority to go into that specific home. You are given a waitlist date of the date that your loved one went into that home. But right now we also have capacity for what we call reunification priority access beds. This came in February or March, I can't remember, of 2018, where the ministry asked all of our long-term care homes to set aside 2 beds that are specific for spousal reunification. So that's for those folks who are living at risk in the community, who are crisis. They have to be deemed crisis because of risk. It can't just be somebody wanting to go in. But if there's a risk situation, then we can actually put them on 2 wait lists. The challenge right now is that most of our RPAP beds are filled, and until it becomes vacant, then, you know, it's not available to us. So it's a good thing, but right now we don't have, most of them are filled, but it's still, I have, you know, had people pass away in those RPAP beds, and I have certainly admitted people to them. And certainly last week, I got somebody into one of our homes who had been separated from his wife for 364 days. So we've had some good stories for sure. The other category is a 2.1, which is those folks who are in a behavior unit, such as we have at Sheridan Villa and at the Cooksville behavior unit. And once those people are stable, they're placed at a higher priority. The next category is a 3A and 3B, and those are people who are those homes are ethnically designated. So Villa Forum, Labdara, and Domlipa in our area are our 3 cultural homes. And so if you are either Slovenian for Domlipa, Lithuanian for Labdara, and Italian is Villa Forum, then you're placed at a higher priority to get into that home. The majority of the people on our wait lists right now are 4As. Those are people with heavy care needs and people who are needing placement but aren't in a crisis situation. And then 4B is the very lowest priority. Now, the Ministry of Health, the rates were supposed to go up in July of this year, and they said we won't be putting the rates up until January, but now we've received notification last week that the rates will not go up until July of 2021. So this is the rates that are currently at the, for all long-term care homes. The Ministry of Health sets the rates, they're uniform throughout the province. The only thing is that the older homes have a slightly lower rate. So anything that's a B, C, or D class home is going to come in at the lower rate here. So the semi-private and private rates are lower. The basic rates are the same for all long-term care homes. Just so you know, and that I should have changed the slide. I missed that. Sorry, it's 2 people. But if you require subsidy from the government, you can only apply for a basic room. So if your income is less than the $1891.31 per month, then you can, the home will help you to apply for rate reduction. And so we don't want folks who can't afford semi-private or private putting pressure on themselves to put that accommodation on. If you need rate reduction, then apply for basic only.
June, are you okay if we take a quick break here?
Yes, that's no problem. Yep.
Yeah, okay. Yep. So 5 minutes, and you're welcome to turn your camera off and turn your microphone off. And
had enough trouble doing that the last time. Let's see if I can figure it out.
Okay.
You might have to look at me.
Okay. Thank you very much. This is very interesting, and very, very few questions coming in right now. That's because you're doing such a great job. So
well, I hope so. But if I, like I said, you know, I'm more than happy to answer any questions that people may have.
Yeah. Okay. So we'll be back in 5 minutes.
Sounds good. Thanks.
Okay. I think we'll get started again. Hello, everybody. Welcome back for a 5-minute break, and we'll get started again. I'll turn it over to June. And okay, you okay, June?
I am. I'm good. I just have to get. Uh-oh. Hang on. Sorry. I just about went to the beginning of it. I would have started all over again. Uh-oh. Anyway, I just I did see there was a question there, so I'd just like to answer that in terms of the difference between basic and semi-private. And that's a very good question right now, because there isn't, well, depending on the home, the configuration, there's always been different configurations. So for example, at Wyndham Manor, basic accommodation is a private room with a shared washroom. At Post End Village and Waterford, a basic room is divided by a curtain. So there has always existed differences within the long-term care homes of configuration. But now with this new change with the ministry no longer allowing 3 and 4 bed basics, what I think long-term might happen is that they might make the semi-private room that was, you know, originally a 4-bed basic, the bigger room, and that the basic room might be the smaller, previously semi-private room. I don't know. At this point, they're just figuring it all out. But what the difference really is in terms of cost. So all long-term care homes are divided. They have to have a minimum of 40% of their rooms basic and then 60% preferred. The older homes, the configuration is a little bit different, but they have assigned which rooms are going to have funding attached. So people may find, in fact, that they're paying semi-private for a similar room than to the basic, but it really is a matter of where the funding is attached, and you cannot get funding for a semi-private room. This is all going to be sorted out down the road. Right now, the goal was just to get those 4 and 3 bed basics out of the system so that people could be safer when the second wave hit. I hope that answers your question. I don't have a clear answer of how it's going to look in the future, but I can tell you it's right now that's how it's looking. So right now, the Ministry of Health, they keep giving us directives in terms of what's safe for visiting families. So really, obviously, the goal is protecting community patients, families, staff, visitors to that's the main priority. And the provincial government is listening to the public health advice and doing everything they can to follow the guidelines. And that's why we see certain areas that are in current restrictions. So I happen to live in Toronto, and so I'm in lockdown. You know, other areas are in the orange area, some are red. So different areas are, you know, experiencing different restrictions. But by and large, none of our homes are allowing just anybody to visit. You are only being allowed to visit as an essential caregiver. And that would be a maximum of 2 people. When the home is in outbreak, it's generally speaking just 1 essential caregiver being allowed to visit. Those essential caregivers have to be COVID tested and have to produce a COVID test weekly to make sure that they're safe. And those in the other areas, they can, it's every 2 weeks. And you know what, people are generally speaking pretty good because we all want to reduce the risk for our long-term care homes. And this has been a very difficult fall, to say the least. When we get a bad offer, the challenge is is that we have to, when we give a bed offer, we have to have a negative COVID result within 24 hours of the person going into the long-term care home. So this is when people ask us, why are the wait lists increasing? That's part of the reason. We have had so many challenges. It is much better now, but in the summer, sometimes we would request a COVID test and the results wouldn't come back for 5 to 7, as much as 9 days. And, you sort of ask the question, if it's that long for the result to come in, how effective is it? Well, things have ramped up quite a bit. We are usually getting results within 24 to 48 hours, and we're getting folks in. We have to get them in within 24 hours at that negative COVID result. It's very, very challenging for our long-term care homes. I can't begin to tell you the pressures that they're under these days. Now, I used to spend a tremendous amount of time talking about preparing people for a transition into long-term care. And I still think there's value in having the discussion now, because I do feel more hopeful today than I did yesterday. And I hope the new year brings more hope for us and that we get our folks vaccinated. Certainly, we do hear that staff, are bringing in the virus from, and we hear that family members and that kind of thing. So we really, really know that getting people vaccinated is going to help. Challenges that I think I said that in this first round, probably the long-term care homes, because of the instability of the Pfizer vaccine, are not going to get that first vaccine, but I do think that ones are going to come quickly. And the quicker we get those folks vaccinated who are in long-term care, and the providers who are doing the hard work going in there, the better we'll be able to see an end in sight to this. For now, we do have to say that we can no longer run tours in the home. So as I mentioned to you, the virtual tour is all that we can offer. I think talking to family and friends, these caregiver support groups that you have, making sure you talk to folks in terms of their experience with the long-term care home that their loved one may be in. Regardless of the fact that things have changed, we do want you to make sure that you think about what kinds of things to bring. So I actually called one of our sorry about that, my tab's here. I actually called one of our long-term care homes today just to double check to find out, what kinds of things they can bring. So they're still saying to bring 2 weeks worth of clothing. That gets laundered by the home. You can bring pictures in. Some homes are reluctant to allow you to bring in larger pieces of furniture. Some homes are allowing it. So when you get the bed offer, you have to ask the question at that time. I was asking, it was West Oak that I called today, and she was saying that they wipe down any items that are being brought in. They definitely launder the items as well, like I mentioned. In each room, generally speaking, you see a bed, you have a wardrobe, you have a side table, and you have a lamp. That's basically standard in most long-term care homes, but sometimes people will bring in a dresser so they can set a TV up in there. So those are the kinds of things you want to think about. What kinds of things, you can bring that will make your loved one feel more at home. Like, I think a duvet, if it's able to be washed, if you want to bring something like that, I think that would be fine. But again, you have to check with the policies. You might want to, at the time of that offer, ask the social worker when you make the calls, listen, what kinds of activities are you running, so that you can sort of talk to your loved one about kinds of things that, they can expect. The one thing I do want you to be aware of, that you have to do a 14-day isolation once your loved one gets into long-term care. So if you can, they usually do some packages of activities that can happen during that time, and, try to make it as comfortable as possible for your loved one. But just if there's things that you can think of that your loved one likes to do, that would be a helpful tool. The other thing I mentioned, I don't know if I mentioned it to this group, but when you know that your loved one is on the wait list for long-term care and potentially could go in during COVID, is if you can practice with those virtual visits and that kind of thing, so that they're familiar with seeing your face on a computer screen. that can be really helpful in helping your loved one settle in. Completing a journal and a photo album and a memory box and all those kinds of things, that's all going to be contingent on whether or not the home will be able to allow those items in. I find the homes that have experienced a COVID outbreak tend to be a little bit more cautious about the items that are being brought in. So again, we got to check with the home first. Having a transportation plan ahead of time. So knowing, listen, my mother, I'm going to take her in the car, we're going to mask, we're going to go together. That's going to be what's best for her. Or my mother responds much better to medical people. So I think I'm going to book transportation and have an ambulance transfer taker. Those are the kinds of things you want to think of ahead of time. You might want to get some pricing and that kind of thing, because there is some variances with pricing. We are noticing some challenges with transportation with ambulances lately because there's so many transfers happening, but generally speaking, things have run pretty smoothly. If you feel that your loved one is going to be resistive to getting admitted to a long-term care home, I really want you to reach out to your care coordinators and have the discussion, because we have lots of early intervention things that we can do to help set up a successful transition. The Behavior Supports Ontario staff from the Alzheimer's Society are great. They put together a plan. They have a good discussion with the families, and even just talking to somebody about ideas and stuff can be wonderful to help you support the transition. Talking to the family doctor. Now, there may be some talk about medications, but generally speaking, sometimes families will say, you know what, my mother will listen to her doctor. She's been going to him for 30 years. So you know what, making sure that you engage the family doctor might be helpful to help with the transition. The doctor might say to mom, listen, you know what, your daughter's been doing a lot, or your husband's really suffering with his health. You know what, it's going to be time to go. And I think now it's time, March, that kind of thing. That can be helpful. Arranging support for yourself. It is an emotional day when you admit anybody to a long-term care home. But what I can tell you right now during COVID, admissions are very, very different than they used to be. So when we previously used to say, go in the day before and set the room up, that's no longer available to you. The maintenance people, generally speaking, set the room up with the items that you've brought. And usually what happens is the paperwork is done on the first floor in a separate room, and then they will take your loved one to their room. So the staff take your loved one to their room, and then you are not allowed in. Usually, I don't want to say 100% of the time during that 14-day isolation. There are some exceptions where some homes have been allowing one visitor. Poston, for example, will allow the caregiver to go up to the room when they're admitted, but that's just a one-time visit for that 14 days. Other homes are a little bit different, so we want to make sure that you know that there has to be some flexibility, and you have to understand that things can change. We can get a directive one day, and then a week later the ministry has changed the rules, and it's all based on public health recommendations. Getting financial and legal paperwork in place is so important. So if you need subsidy, I beg you to get the taxes done and make sure you have that notice of assessment so that admission day they can determine what the rate reduction can be. Without that notice of assessment, it becomes very complicated. So getting that done, if you can get the power of attorneys for personal care and finances in place before, it's very helpful. They'll want you to bring your health card. They want you to bring 2 void checks. Those are the kinds of things you want to make sure you have ready, because some people don't have checks anymore because we're all tapping. Well, you need to have 2 checks to bring to the admission. Family dynamics, as I mentioned to you before, when siblings don't agree and they are not on the same page, or mom, I had a gentleman, God bless him, who did everything to support his wife and got her admitted to long-term care. Because he had just completely burned out, and the kids were so upset. He ended up taking his wife out because of the, frustration that his kids were not happy about the admission. At the end of the day, he was still the one who provided the care and experienced the caregiver burden again, you know, a couple of months down the road and could no longer cope. So just having the discussion and using the community supports and all the wonderful counselors we have out there to try and help everybody sort of come on the same page, so that when the admission come, you're not in that situation where there's disagreement, because it's already emotional. If you add, you know, family dynamics to that, it becomes even more emotional. And then the last point is start thinking about advanced care directives, because it is something that you're going to be asked. So do you want a full code? Do you want your loved one to receive antibiotics and interventions? Or are you looking at, you know, just end of life support being provided at the long-term care home? So those are things you want to think about, and thinking about it on an admission day or, you know, a few days into the admission can be difficult. So thinking about it ahead of time can be helpful. So, you know, we are always asked, can you give me the wait time for this particular home? And in the past, we would provide wait time estimates by looking at our wait list and seeing how long the person who'd been waiting at the top of the list had been waiting, and kind of give people a general idea. But right now, we are not able to provide estimated wait times because the crisis list has grown just exponentially, and because the admissions are being limited, and because we cannot admit to a home that is an outbreak, and we have 19 homes right now in outbreak, it's delaying the times that we are able to admit people to these long-term care homes. So it has become very difficult to admit people into, give people estimated wait times, okay? One thing that I do want to tell you is that we are actually letting people, so if you are discussing crisis placement with your care coordinator, they're going to ask you, will you be willing to admit your loved one into a long-term care home during the pandemic? Because we don't want people on the crisis list whose loved ones don't want to admit them during the pandemic, because, you know, first of all, that's a waste of everybody's time. But certainly we're having our homes review applications when they're already extremely busy with providing patient care. If you don't have any interest in doing it during the pandemic, we would not put you on the crisis list, but we would allow people to say, during the pandemic, we don't want to receive a bed offer. And we ask our care coordinators to ask families that, and we're just sort of documenting family do not wish to admit their loved one during the pandemic. So if somebody happens to come up the wait list and we ask the care coordinator to complete updates, they're going to ask that question, because we don't want people to admit their loved ones if they don't feel comfortable doing it during the pandemic. So I just wanted you to be aware that you can certainly say that. If a bed offer is declined, then we do have to close the placement file, and you're removed from all wait lists, not just the wait list that you received a bed offer at. The file is closed. And I've done so many presentations where people said, and then I moved to the bottom of the list, but that's in fact not true. You are actually having to start the placement application again. You have to wait 3 months to reapply, unless there's a change within your that 3 months that your loved one declines or something happens. We can certainly reassess within 3 months, but if everything remains the same, then you do have to wait the 3 months to reapply. And so we hate to see that happen. Because, you know, people wait for a long time, but, you know, it's difficult to predict with wait lists. So I understand people's frustrations for sure. Casual leaves and vacation leaves, as I mentioned to you, are no longer allowed. But just so you know, for the future, vacation leaves are up to 21 days and casual leaves are up to 48 hours in a 1 week period. So if, for example, when it's not a pandemic, somebody wants to take their loved one home on the weekend, they can take them home for 48 hours and then they can go back to the home. If you want to go on a vacation, you can have up to 21 days in a calendar year to take your loved one on a vacation. But during the pandemic, all casual and vacation leaves have been stopped. And if people take their loved ones out of a long-term care home, they are discharged from that home. And then, as I talked to you about before, they would be considered a readmission to go back to the home once the outbreak was cleared. So we'd have to have a communication with the LHIN. So you say, listen, I'm taking my loved one out, and we would work through a plan. I have had many conversations. Many times people decide not to do it after they sort of understand all the implications. But as I said, we have had some folks take their loved ones out. Now, in terms of resources, these are some resources that you can access. You know, if you're looking for resources, for community resources, and you want information on services, these are websites that you can look at. I don't know if, oops, somehow I clicked something, I apologize. The other thing I wanted to explain to you is if your loved one is in a long-term care home and you have issues and you are upset by something that's happened there, the first thing we always say to people is, please talk to the home and try to resolve it within the home. So if you have, you know, a charge nurse on the floor and say, listen, this happened and I'm just a bit concerned about that, or I noticed this, try to resolve it within the home. You know, if you can't resolve it with the charge nurse or the staff who are involved, then escalate it up to the director of care or the administrator and try and resolve it within the home. But if you cannot resolve it within the home, then there is a long-term care action line that you can report any concerns to them, and they will do an investigation. It will be anonymous. They will go in and they will say that they're going to check, you know, on so-and-so number of people, and they won't know that you made a complaint, but they certainly, if there is fault found within the home, then the home will have to put a plan together and report to compliance how they're going to mitigate this risk in the future. So it's important that you know that's available. If you have issues with, for example, your loved one is in the hospital and there's something that you're dissatisfied, you can always call the hospital ombudsman. If you have an issue with the LHIN and some of like your care coordinator, you're upset, you know, something's happened, you don't like the way your case is being managed, you can certainly ask to speak to the manager. And then we have a patient relations department. Catherine Hales is head of that. She's great, and you can talk to her. We can, you know, try to resolve it internally, but there is a complaints process that you can go to. But the other important number that I want you to be aware of is the Advocacy Center for the Elderly. I'm sure many of you have seen Jane meet us on the news lately, and she has been a strong advocate for our seniors for many years. Any complaints that you have, you can certainly call the Advocacy Center and get some legal advice from them. So that is really pretty quick. I did it in an hour and a half because I usually have so many questions and people who are loving to share their stories with me. And I have to say I miss that, but I do want you to know that if you have any questions for me and you would like to, you know, get some advice or share your story, or just, you know, tell me something, or, you know, tell me something I need to improve, you can call me. My extension's 5547. And I work Monday through Friday, and I am more than happy to answer any questions you may have. I know it's a difficult time. I do want to give a shout out to all of our long-term care home staff who are doing everything they can to keep their residents safe, and who have been really fighting a very difficult second wave right now. I was telling Sandy and Vanitha and Tala that I was listening to the CBC on Friday, and I heard somebody call in and dedicate a song to one of our long-term care homes and giving them a shout out for all the great work they're doing. And we heard so much about our healthcare providers in the spring, and I just want to mention, you know, all the great work that they're doing and how hard they are working. Many hours. What we have noticed lately is that they have lost a lot of staff when they changed. It used to be that people would work in a number of different homes, and when they changed that you could only work in one home, you know, the other homes lost staff. So they've really been working hard to build up their staff. And, once an outbreak happens and people are, having, are off on isolation, self-isolating, then the home is already dealing with less staff and they have to bring in agency staff. So I just wanted to mention that they're really, really trying hard to take care of their loved one, your loved ones in long-term care. And, I just hope that everybody stays safe and keeps these folks in mind over the Christmas season as we try to keep our visits and our Christmas to our own homes.
Thank you, June. Thank you. That was wonderful. I certainly know what you mean. I certainly know what you mean by lack of questions at this time and it being a very different audience.
Usually Sandy's putting all the chairs away while we're talking. Right?
So, yeah, somebody did raise their hand and
I didn't see it. Sorry.
No, well, I'm not quite sure how that works. Do you want to look at the one question? There is one question there, and the person who raised their hand, if you don't mind typing your question into the Q&A box.
Oh, I see. Oh, are there any additional differences between the information you mentioned above? Oh, okay, that's a good question. There should not be different information in terms of the long-term care home process. What I can tell you is that Burlington is under a different, Lynn, and so what I have noticed, because I get them emailed to me every day, there are far less homes on outbreak in the Burlington area. But the process for applying for long-term care is the same. The wait lists, are also quite long in the Burlington area. I know they have a lot of pressures with their hospitals, just the same as we do. So I wouldn't say it's any different. The directives from the ministry are province-wide, so they have changed all their long-term care homes or are in the process of changing to 2-bed basics as well. So I don't think you're going to find a huge difference. I think it's pretty much the same.
Okay, thank you. Now somebody has raised their hand and I've not done this before, but I'm going to see if I can. Apparently,
while you look for that, Sandy, I have one question here.
Great.
About the rate information. June, if you don't mind going back to the long-term care rates.
Sure.
Question is, you had mentioned the changes to basic room capacity to only 2 residents now.
Yeah.
Was your long-term care rate information outdated? It mentioned 4 in a room.
Yeah, that's what I said. That when I was reading it, I said that part we missed when we rewrote the presentation. So it is 2 people in a room.
Mm-hmm.
Yeah.
Thank you.
Yeah, sorry about that. I'll have to get that corrected.
Okay.
Maximum of 2.
Melissa, are you able to ask us a question? Melissa's out there. She had her hand raised. No.
Sorry, I actually didn't have a question. It was a mistake. I apologize.
Happens at work all the time.
I just looked down. I was like, oh, is she talking to me? Oh yeah, I must have pressed that by accident. Sorry.
Well, thank you, Melissa. I just learned that we can actually have people speak to us on these webinars.
Oh, that would have been great. Yeah. Yeah,
my apologies.
And you can do it anonymously in a way, because I wouldn't know who's asking the question, but I really don't mind any challenging questions or anything like that. So as I say, anybody who has anything that they wish to ask, I'm more than happy to answer you as honestly as I can.
June, I have 2 more questions here. I'm not sure if you can answer this first one. It says, can you give an estimate of how many people are on Ontario's waitlist for long-term care?
Ontario? Ooh, no.
Particularly in Halton.
Like, I should have listened to that on the news, but thousands for sure. I mean, in our long-term care homes, like just on one long-term care home alone, I have like 950 people on the wait list for one home in Oakville. Yeah. Right. So the wait lists are long, and the crisis lists, have to hundreds now. And that is new. because of the pandemic. And we do know, and I actually meant to mention this, and I do apologize, but we have heard from Premier Ford that we are going to be getting long-term care home capacity, new builds, and they're really trying to push forward. But the thing, I don't know when they're going to open, but they're looking at fast tracking a number of beds near Trillium, and certainly Oakville is looking at a location there. So right now, I can't give you a good picture of what's happening, but we do know the ministry is well aware of the gaps and the pressures. And so I really feel like the wait lists are going to improve. Like once this pandemic is over, we will be able to see a different picture. We know we need more capacity. What I do know also is they're looking at increasing some services that are available to try and support people, because we know people in the community are hanging on by their fingertips. I don't know when the program is going to roll out, but we're really trying to help people. And you know what I just remembered? I'm so sorry I didn't mention this. One of the challenges that we are having in the Mississauga, Halton, Lynn, is admitting people to secure units. And I know this is the challenge within the community for families who have their loved ones who are exit risks. And so, but the problem is that within a long-term care home, they have to do that 14-day isolation. So what that means is that they have to put in high intensity needs for 24 hours a day for 14 days. And some homes are open to doing that. It's not that, it's just they lack the capacity within their staff because of the pressures to be able to do that. So we're looking at alternate ways of trying to support that, because that's been the barrier for us getting people into the secure units. So I'm hoping over the next while we'll see an improvement, and we did get some folks into the secure unit, but it's been slow. So let's say somebody admits somebody to a secure unit. For the next 2 weeks, they don't have the staff to admit another person, because then they have to have 24, for them as well. I mean, so this is what the challenge is. So they're looking for all sorts of creative solutions, because we know these families are the ones who are really, really suffering right now. So I want you to know that everybody in the Lynn is aware of it. The long-term care homes are aware of it, and we're trying to look for creative solutions with the staffing complements that they're looking at to try and be able to get people into long-term care home who need secure. And was there another question I think you said?
Yes, there's one more question on matching residents in a long-term care home. How do they determine how to pair the residents? Same medical diagnosis and stage of condition?
Are you speaking about admitting somebody into a basic room, and how do we match them that way? Because
I would think so.
Okay,
yes.
So what I can tell you is we have to go by the wait list. So let's say a basic room becomes available. I have to go to the next person on the wait list. One thing I can tell you is if there is a situation, because we're really not allowed to bypass people, we have to present them and admit them. But if, let's say somebody was going to be admitted to a room and that other resident was territorial, and the person I was going to admit was hoarding, that in itself would be a difficult match. So we may in fact not do that. In general, we have to go with the next name, but we are not going to put anybody at risk by admitting them to a room that would not be, a good setup. What may happen after they're admitted is that they would, be moved internally to a more appropriate roommate. That does happen within, like I've had situations where they said, oh, that room's no longer available. We had to do an internal transfer. That's more than likely that what would happen. Now that I mentioned internal transfers again, I do want to mention to you, sometimes people, when they're in a crisis situation and they need to go in, they will put on semi-private or private accommodation. I should mention to you, if you can afford to do that for about 18 months to 2 years, then you can, upon admission, ask for an internal transfer to a basic room. We do have people do that. So I should mention that to you as well, as if you have the finances to do it for, let's say, a couple of years, then that's an option. You can always move internally. A lot of times people get on an internal wait list, but they don't want to go to a different floor because they're used to the staff. So, you know, wait lists can vary internally. So usually they say you can expect to wait a couple of years. I had somebody admitted to one of my homes, and I thought it would be a couple of years, but because a room came up and none of the other people wanted to move off their unit, he got changed, I think, within 2 months. Doesn't usually happen that way. It's usually a couple of years. So that's something to keep in mind as well if you find yourself really urgently needing placement.
Thank you, June.
Okay.
Yeah, thank you, June. I'm not seeing any more questions right now. And June, would you mind repeating your phone number again for people in case they want to reach out to you?
Yeah, it's 905-855-9090. I think that number's on the presentation, but my extension's 5547. And there is only one June in the whole organization. So if you can't get it by my extension, you just press 0 and they can put you through to me. Because we have our phones now on our desk, so we have them at home, so we can certainly take any call. And I'm more than happy to talk to anybody who might need some sort of personal advice.
Okay, that's super. Thank you so much, June. And I also just want to take a moment to thank the behind the scenes crew here. Vinitha and Tala have both been working behind the scenes tonight. And also Tala has been working behind the scenes for a few weeks now with Vinitha. So thank you to both of you. And we are now going to launch our poll. There's Vinitha. And we're going to launch our poll. And if you please don't mind answering the questions we have there. Again, that helps us look at our education. And we will look forward to seeing all of you next week for the self-care for the caregiver. So thank you very much.
All right, take care and stay safe. I'm going to hang up now so I don't see anything.
Okay.
All right, take care.
Thanks, June.
All right, nice seeing you. Or I saw you.
You did. Bye.
Bye.